Thank you very much. Thank you very much for having me. So yes, I'm going to be talking about deploying AI in the NHS. Um, as you said, I'm a cardiology registrar in London, and I specialise in adult congenital heart disease. But a few years ago, I did a sort of time out of training to do a clinical fellowship in artificial intelligence. And so I'm going to just talk through that process, that fellowship. If it's something that some of you might be interested in, it was a really amazing opportunity. And as part of that, I was given a project to deploy an algorithm in the NHS, which I'll talk through as well. So this is the fellowship. This is the website that advertises the fellowship in clinical artificial intelligence. And this was started a few years ago in conjunction with Guy's and St Thomas's Hospital. And I was part of the first cohort of clinical fellows who were taken through this. And it essentially is a 1 year placement where you have 2 days a week where you're given formal training in AI methodology and in how we can apply AI in the NHS and how to evaluate clinical algorithms. And this is the first cohort that joined with me. And we had a lot of seminars and workshops talking about AI governance as well, how we can make AI safe for the NHS. And we were each given individual projects which we were to take to a trust and try to integrate into that trust to try to improve clinical practice. And it was a really amazing opportunity to try to get clinicians engaging with AI, a very challenging one as well. And part of my project, I wrote up a sort of 5-step guide, which I then published on how we can safely adopt AI tools in healthcare. And so I'm going to just talk through that basically with using the example of the project that I was given. And it seems very, very obvious, but the first step was really to identify what the clinical problem was that needed to be solved within the trust where I was so that we could then find an AI solution. And this seems very obvious, but actually, a lot of commercial companies and researchers develop incredible solutions, but it's not totally clear what problem they're trying to solve. And I think sometimes we miss that step of finding out what it is that needs to be solved, what problem is actually occurring in the NHS, of which there are many, and then tailoring the solution to that problem. So the first thing that I did was I was placed in a trust in East Kent. This is Kent and Canterbury Hospital, and so I was placed there and asked to deploy an AI solution for them. And the first thing I did was I held a series of workshops and did some surveys to find out actually what kind of problem they wanted solving. And it quickly became clear that they had an enormous backlog of chest x-ray reporting. So they had a policy where each chest x-ray that was taken had to be reported, but this was taking anywhere between 7 days and 30 days in some cases to actually get that report done. So they were swamped in chest x-rays. They really wanted something that could speed up that process. And so we thought about how we could solve that problem. So then my next step was to try and actually find what tools would be suitable for doing this. So I was thinking about how we could create something that automatically reported chest x-rays and gave an instant report for clinicians so that we were really cutting back on this massive backlog that they had of their chest x-rays and reducing the work for the radiologist. And after looking on various frameworks and areas where the NHS has found solutions, I found Cure, which is an Indian company who's designed lots of different algorithms for automatic reporting in radiology. And they have a software called QXR, which gives an automatic report for chest x-rays and identifies an abnormality, creating an overlay next to the original image so that you can see exactly what the algorithm has identified. And this looked like a really good solution, and the algorithm was very well trained on millions of chest x-rays from across the world. But when I looked into it and just chatted with the company, it was clear that they actually hadn't done any degree of external validation on this software. So that was my first step, which was to take 1,000 chest x-rays from the trust where I was working and run the algorithm to check that it was still accurate for the x-rays that we were using in that trust. And then I published this validation study, and it showed that actually the chest x-ray software was very accurate and was very safe for us to use. So after this process, I could then go back to the emergency doctors, the radiologists, and say, okay, we know that this software is safe. We can try to roll it out in the department. So the next step after that was to actually plan for the implementation and find the right people in the trust who could help me to integrate the IT, to establish what we wanted from the project. And this was a crucial step of getting the buy-in from all the right people. And this was a really quite a large team. We had the radiology department, the emergency department. We had to get representatives from procurement because we were then paying for this software. So we had to write a business plan to get the funding for the software. We had to engage with the information governance director. And as part of the AI fellowship, they actually give us a lot of training in AI governance and how to make sure that we are risk assessing our AI software and then auditing it long term to ensure it remains safe and accurate. So this was very useful for the process with the information governance director because I was able to do a risk assessment, present them with the correct documents, and get through that process, which the trust was very keen on. We also then liaised with the IT director to make sure that we could integrate the software, and then we were working with the commercial company and their software developers as well. So it was a big team, and we needed to make sure that we were all working to the same aims. So what we were trying to do was to improve the immediacy of chest x-ray reporting. So we wanted to reduce the backlog and also get very accurate reports as well. We wanted to create work lists, so tag the x-rays as normal and abnormal. And this was something that the radiology team requested because what they wanted was a way of prioritizing which scans they would actually look at, and make sure that they looked at the abnormal ones first. The plan was then to just audit the films that were tagged as normal to check that they were actually normal and just monitor that post-deployment, and then eventually get to a point where we were happy to potentially consider not reporting the normal scans at all. So then we had to do complicated IT integration, and this step was one of the most painful. It is very challenging getting new software into the NHS, and there's a lot of hoops to jump through. So it was really important that we liaised with our IT directors and managed to eventually get the software onto the right machines and into the PACS system for the clinicians to use. And this is what we created as a report that went alongside the original image. And it was really important that we still had the original image displayed because we had a lot of requests saying, oh, we still want to be able to train on the radiology trainees, still wanted to be able to see the original picture so that they weren't losing any skills in interpretation themselves. So this is the display, and you'd see that the algorithm would ring the area that was abnormal and then mark what it thought it was. And this would occur instantly once the chest x-ray was taken, and it would tag it as normal and abnormal at the top. So once we'd deployed the software, we then needed to continue to monitor it and audit it to ensure it was safe. We also trained super users who were radiographers who would be able to troubleshoot any problems that we ran into after it had been deployed. And so we audited over a period of months following deployment, just testing, checking the accuracy of the software on a few tens of x-rays per month to make sure that there was no changes with any software updates or anything like that. I've then written up the project in an article. So this is a bit more detailed from what I've gone through now, but it just gives a bit more information about the process and the steps that we took, and is essentially a how-to guide for clinicians, which is to try to make it as easy as possible to use AI algorithms in the NHS. So my projects now are more towards congenital heart disease. I think there's massive scope for AI within congenital heart disease and just to integrate technology more in general. I've written an article recently about how we could potentially really streamline follow-up for complicated congenital patients by integrating more telemedicine, more remote monitoring, wearable devices, and AI prediction models to try to reach patients who are in places that are further away from tertiary centres, who aren't as likely to travel, so that we try to get more equality in healthcare for these patients. Another project that I'm working on is trying to update this algorithm, which was published a few years ago by the Brompton Group, which basically they have a huge cohort of congenital patients, and they have that data available. And so at the moment, we're trying to update this algorithm to try to create a very accurate risk prediction model for ACHD patients that will predict hospitalization and mortality longer term, so that we can try to target patients who are more likely to have worse outcomes. So that's something that I'm working on at the moment. And just to say that there, you can access the AI Fellowship webpage from this QR code, as well as the guide that I wrote on how to deploy AI in the NHS. And please, if you have any questions about either of those, then do get in touch with me, and I'm very happy to take any questions.